Para mí inglés también.
Sí, seguro.
Good evening and welcome, everyone. Good evening and welcome, everyone. We'll ask people to get their food and we'll get started. Welcome to this Peer Review Live event. The title of today's session is Catalyst for Enhanced Patient Care in Neuroendocrine Neoplasms. A lot of developments this year in neuroendocrine cancers, and we're hoping to share that to you in a way that is case-based, practical, and hopefully can help understand some of the novel therapeutic strategies and how it may impact patient care. So again, welcome. My name is Singh. I'm a medical oncologist and professor of medicine at the University of Toronto. I have with me, and we're going to introduce them as their sessions comes up, Dr. Yami Capdevila from Val Hebron and Dr. Diane Reedy from Chapel Hill. Thank you to Peer Review and NCAN for providing support for this session, Boehringer, Exelixis, and Novartis for the grants. There is a pre-event survey, and there'll be additional polling during the presentation, so have your phone ready. When you have questions, I'd encourage you to submit them through the QR code. That way we can see them and make sure that they get addressed. We will have opportunities for live questions as well, but I would encourage you to consider submitting them through the QR code. We also have virtual people online, and for those people, we're going to also ask you to submit your questions electronically. For those who are able to, there is a $50 gift card available that the more times you participate, whether it be a poll or a question, the more times you're going to get entered. If you see the symbol, one of the peer review people, talk to them and they'll be able to give you your prize. So the more you participate, the more you have a chance at winning. And again, thank you to Peer Review for putting this on. They also have the slides and practice aids available now that you can download and use either during the session or after the session. And with that, as I mentioned, our goals today are to help understand how we diagnose neuroendocrine cancers. It's going to be a general overview. We really want to concentrate our time on the latest clinical trial data, and I've got two amazing colleagues here to help me walk through that. We're going to talk about how we can use this data to help create tailored treatment plans, person-centered care for our neuroendocrine patients, and also to look at what kind of tools may be available. And hopefully during the presentations, you'll also have a sense of where we're moving in neuroendocrine cancers, the clinical trials, the patient education and engagement, and how we're considering adverse events. A special thank you to NCAN, who's a partner with this. NCAN is one of the large patient-based organizations supporting patients with neuroendocrine care. They have a table outside, and for those who are providers, I would encourage you, when they're looking for support, to consider NCAN. They have, as you can see here, a very long history of supporting patients with neuroendocrine cancers. Okay, so with that, let's get into our talk. So, neuroendocrine neoplasms are a very diverse group of cancers, and it truly is probably more than any other malignancy. We see a fair amount of variation. The reason for that is because it's not limited to one organ like many of the other cancers. It can arise from any of the diffuse neuroendocrine system throughout the body, and I think if you talk to the panelists here, they'll talk to you about very different spots that they have seen, including some very obscure spots. I've had a eustachian tube, for example, neuroendocrine neoplasm. They have heterogeneous pathology, and I hope to talk to you about that briefly. The other thing that's unique about the neuroendocrine neoplasms, of course, is, we have the malignancy that we're dealing with, but in many cases, we also have hormone secretion. So we're dealing with two issues often. We're dealing with the malignancy itself, and we're dealing with the paraneoplastic hormone secretion that is too common with these cancers. The other thing that's to be noted about neuroendocrine neoplasms as we start is its rising incidence and its rising prevalence. So originally this was thought to be a very rare cancer, and people thought it probably wasn't worthy of a lot of research or discovery, and what we're finding is that that's probably not true. As you can see here on this graph, take it to scale, of course. This looked at the SEER database in the United States, and we can see here that despite a rise in overall malignant neoplasms, the rise in incidence of neuroendocrine neoplasms has been at a much faster rate. And in fact, we're almost at now 8 per 100,000 in terms of incidence. That rise has been seen in numerous sites, including lung, small intestine, and rectal, and we're mostly seeing this in localized low-grade disease. This also means that prevalence is increasing, which means more patients are living with neuroendocrine neoplasms than ever before. Now, when it comes to understanding neuroendocrine neoplasms, terminology really matters. So I want to take a few minutes to walk through this so we're talking a common language. And this has been a problem with treating neuroendocrine cancers in the past, has been this lack of a common terminology. So first of all, we think about differentiation. Well-differentiated neuroendocrine cancers are denoted as tumors, so well-differentiated neuroendocrine tumor, or NETs. Poorly differentiated neuroendocrine carcinomas are NECs, and there's a big difference between the two, as we're going to talk about. We further subdivide the neuroendocrine neoplasms into grade based on Ki-67 staining. Ki-67 is an immunohistochemistry stain that looks at the number of cells replicating. And as you can see here, even for the non-pathologist eye, the differences can be quite stark in terms of grade 1, where we see very little replication, and grade 3, where we see a lot of replication. Now, when we think about well-differentiated NET, neuroendocrine tumors, grade 1 is a Ki-67 of less than 3%, grade 2 is 3 to 20, and grade 3 is greater than 20. Now, this is, of course, very different than poorly differentiated NEC. That's by definition a grade 3, but we further divide these into small cell NEC and large cell NEC, especially when we're talking about the lung. Sometimes deciphering between a NEC and a NET is not as simple as we would think. This entity of a well-differentiated high-grade NET, well-differentiated high-grade neuroendocrine tumor, is a fairly new phenomenon that's only been classified in about the last decade or so. And deciphering between a neuroendocrine tumor, G3, or a high-grade G3, and a neuroendocrine carcinoma can sometimes be difficult. These are some of the differences. We use morphology to help us, but we can also see differences in P53, RB loss with the more aggressive tumors. We see loss of SSTR staining, as well as potential genetic changes like DAX and ATRX being more positive in the NECs. But just to make it clear, it is sometimes difficult to decipher between the two. And we now understand that there is likely an entity called the well-differentiated G3 that we hadn't really thought about before. As I mentioned, hormones are a crucial part of the consideration when we're treating patients with neuroendocrine cancers. For the foregut, primarily the lung neuroendocrine tumors, we think more of ACTH and histamine secretion, although serotonin can be a culprit here as well. When it comes to the small intestine, it's primarily serotonin-based. What we think about is traditional carcinoid syndrome. And with the pancreas, there's a variety of endocrinologies that can be affected by the paraneoplastic syndrome here: insulin, gastrin, glucagon, VIP, somatostatin, a number of them. And so it's really important to listen to your patient's symptoms, to do the appropriate testing, and to be able to identify not only the malignancy, but also the potential paraneoplastic hormone secretion. When it comes to diagnosis, I mentioned to you that a lot of the growth has been in low-grade localized disease. Often endoscopy can be used for the diagnosis. Video capsule endoscopy has been used, but has not been as successful as direct visualization. But really, primarily, we're considering imaging. Helps us to understand the disease and to be able to stage it appropriately. CT and MRI, traditional cross-sectional imaging, remains the mainstay, I would say, of staging of neuroendocrine tumors. However, functional imaging, such as gallium-68 or copper imaging, is very important moving forward to try to understand not only the staging, but to understand that SSTR2 status, the receptors, which may affect not only the prognosis and help us delineate the best treatment, but also helps us select the appropriate treatments for patients. Somatostatin receptor imaging has become very important. It's much more prevalent on well-differentiated neuroendocrine tumors. The SSTR PET is the preferred, given the higher sensitivity and spatial resolution. Octreotide scans were used previously, but aren't used as much anymore. The most common tracers used are gallium and copper, although copper is continuing to have an increased uptake in its use and its spatial resolution. Lesions are considered as compared to its liver uptake. So this should be a baseline part of any tumor workup for neuroendocrine cancer, should be SSTR imaging. Most recently, Dr. Hope and a group of neuroendocrine treaters took a look at to try to understand when this imaging should be done. As you could see here, it really involves staging, localization, and to determine if the patient is eligible for SSTR targeted PRRT. Now, for some treatments, such as we're going to hear today, such as cabozantinib, for example, the SSTR imaging is not as important because it is in both SSTR positive and negative disease. But for some of the treatments you're going to hear about today, like PRRT, SSTR imaging is essential because we need to know if those receptors are there. So as I mentioned, as we go through today, there's a number of treatment options we have for our patients. Neuroendocrine cancers are a challenging tumor to treat. It's multidisciplinary by its very definition, given the amount of treatments that we have and the sequencing uncertainties that we have. But what we really aim for is to try to build our care around the patient with the appropriate diagnostic tools and then the right team that can build the right therapeutic tools around the patient. So before we go on to the next session and start to talk about some of the new developments, I'll ask you to take a moment to look at the poll that we have on the QR code here. It's a question for you to reflect and to be able to take a look at. And again, the more times you take a look at the QR code, the more times you have to win. So with that, I'm going to move on, and we're going to start to talk now about some of the different systemic treatment options and innovations that we've seen. And here I'll be joined by Dr. Reedy, who's the Chief of Medical Oncology and the Vice President for Oncology Services at Duke University at the Duke Cancer Center in Durham. So when we think about the well-differentiated GI net, we have a number of different treatment options available right at the onset. We often think of surgery initially. Of course, if the tumor is resectable, surgery is often a preferable choice. And sometimes we even do debulking surgery. And although sometimes controversial, it's generally been accepted that removal of the primary in many cases can be beneficial for a patient, even in the face of metastatic disease. In some patients, with close discussion with the patients and the providers together with a shared decision-making framework, we may decide with low volume, slow disease, that observation is an option with close follow-up. This would be in cases where we're sure that we can, in fact, we have compliance with observation and that the patient will come back for their follow-up. Now, in some cases, with more the opposite, with significant disease burden or aggressive biology, we may decide to move to a more aggressive course. Primarily, the treatment for well-differentiated gastrointestinal nets has been somatostatin analogs, and I'm going to talk to you a little bit about that. But now we are also having emerging data for first-line PRT in some of the more aggressive neuroendocrine tumors. You may recall I mentioned to you that the G2 neuroendocrine tumors have a Ki-67 from 3 to 20. We're now talking about an entity called the high G2 of the Ki-67 on the higher end of the G2 and the well-differentiated G3, and they may benefit from first-line PRT, and we'll talk a little bit about that. Upon progression, we're getting more and more options. Of course, clinical trial always remains an option, but PRT with lutetium dotatate for those patients who are SSTR positive, but we now have treatments such as everolimus that have been developed, and now most recently cabozantinib that shows to be effective in patients. So we're really increasing our treatment arsenal. Again, we can't forget about the hormonal secretion, and those they may be concurrent with your anti-tumor care, or they may have different pathways, such as liver-directed therapy or drugs such as telotrestat or other systemic therapy, where the aim would be to decrease hormone secretion, improve the patient's quality of life, and prevent complications downstream. When it comes to pancreatic NET, again, maybe not as much evidence, but we still do consider surgery, especially in the case of where it's localized. There is opportunities, again, for asymptomatic low-volume disease, although we do know that pancreatic neuroendocrine tumors are a bit more aggressive, so generally we may want to start these patients on treatment. And again, we have the same options that we talked about in terms of somatostatin analogs, primarily being the treatment. However, in more aggressive cancers, we may consider PRT, we may consider chemotherapy, although the evidence for that is still being developed. And then, of course, as mentioned, drugs like cabozantinib or PRT beyond progression of an SSA. So a lot of different options there, and so how do we go about making those decisions? Well, of course, we're going to put the patient at the center and think about things like what's appropriate for the patient, not only their preference, but what are the medical comorbidities, what's their performance status. We're going to think about the disease. Where's the site of origin? Is it GI, pancreas, or lung? And our data varies slightly depending on that. What's the tumor grade and differentiation? How aggressive is the tumor? As I mentioned, SSTR expression is very important, not only for understanding the differentiation, but also for understanding treatment options that may or may not be available to patients based on SSTR expression. I think more and more we look at pace of disease progression. The biology declares itself, and the pace of disease progression helps us understand how aggressive we need to be at what stage with our patients. The presence of symptoms, of course, when we're putting patients at the center is paramount. We think about tumor bulk, but we also think about the hormone secretion, and we also want to think about how extensive the disease is when we're making some of these decisions, and we're going to get into some of this with a case-based discussion. So let's start our discussion here with a case of a mid-gut neuroendocrine tumor. This patient is a 55-year-old patient who has SSTR positive, so had an SSTR imaging and has a positive disease. She was diagnosed with a mid-gut neuroendocrine tumor with a low Ki-67, grade 1, Ki-67 of 2%. Let's say that it's metastatic disease and non-operable. The SSTR expression was detected via the SSTR PET. And the patient has otherwise good medical history, adequate bone marrow, renal, and hepatic function. So maybe I'll turn to my colleagues now and think, Diane, how would you think about your first approach be to this patient?
So as you said, Simran, I think the first important thing is thinking about, is the patient asymptomatic or symptomatic? And then importantly, what do those scans look like? Is the burden of disease high, where I'm worried that a little bit of growth could cause some trouble, or is it low volume disease? So in some of our patients, a very short interval follow-up with observation could be very appropriate, because if we do just a quick scan, 3 to 4 months, and it's completely stable, we just save that patient 3 months of surgery, of therapy, right? Because there's no free lunch in life. And so every treatment has some side effects, even if it's just a shot in the bottom, which I would think our first line therapy is. So I think if the patient's burden of disease was higher, typically in a low-grade neuroendocrine of the small bowel, what I call our first string players, the best treatments would be somatostatin analogs, either octreotide or lanreotide.
Yame?
Yeah, of course, it's the first option, and I fully agree what you said. It's important to know this tumor growth rate, because then you may expect, you will calculate your expectations on the systemic therapies, because you may start analogs up front, but if the tumor is really progressing and you don't know that, the benefit of this analog at medium term will be quite shorter compared with those that really do not grow together with the tumor volume at the end. So these are the slide that you showed with the different characteristics, tumor-based and biology-based, are extremely important to decide the first treatment option.
Yeah,
Diane, for someone like this who has low-grade disease and we don't understand the pace of growth, would you try a watch and wait approach with close observation for all your patients, or are there select criteria that would help you decide?
So I think the NCCN guidelines helps us in this respect. It tells us that we should start treatment for 3 reasons. 1 is disease growth under observation, which we don't have yet. 2 is high burden of disease, which is symptomatic, but I think we all know it when we see it. And 3 is symptomatic disease, where the patient has either symptoms from hormone-related cancer symptoms, or that their burden of disease is causing anorexia or nausea or pain or something like that. And I kind of hold that as a tenet. To what we said before, yes, we worry if we that little bit of the test of time could tell us if the cancer is growing faster than we think, and then we're going to go on to maybe a more aggressive treatment. But the converse of that is also critically important. If I start a patient with very low volume, asymptomatic, low-grade disease with octreotide, and 3 months later, lanreotide, I do a scan and it's stable, I don't know if it was the drug that helped stabilize it, or if it was just indolent biology that could have been watched for years, and I could have kept that card to play for a later time.
So I think what we've heard is that somatostatin analogs, if we were going to start treatment, somatostatin analogs would be an important part of this patient's first-line treatment. So let's talk a little bit about somatostatin analogs. There's been two large trials that have established somatostatin analogs and still to this day remain I would say the foundation for most of our care of neuroendocrine cancer, the PROMET and CLARINET trial. Some important differences, they're two separate agents. Octreotide LAR is a 30 milligram dose given intramuscularly. Lanreotide is 120 milligrams given what's a deep sub-Q. The trials are slightly different. The PROMET trial was smaller, looked at only at mid-gut neuroendocrine tumors, mostly had a Ki-67 less than 2%, although that wasn't an entry criteria. CLARINET, however, was a bit more widespread with the GI and pancreatic neuroendocrine tumors, limited to non-functional or non-hormone secreting symptomatic tumors. They had to have a positive octreotide scan, and the Ki-67 had to be less than 10%. Now, you'll see here slightly different median PFS and the time to tumor progression. Part of that's due to the different patient populations as well as the way that we've measured progression here. But nonetheless, I think both of these showed that the somatostatin analogs are cytostatic, not cytocidal, as you'll see by the very low response rates, but remain a good effective treatment for first-line therapy. When we've looked at some of the higher dose than what we've seen, there may be some potential there to use higher doses. We're going to talk about the NETTER-1 trial in a few minutes, but if we look at the control arm, which was 60 milligrams, we did see almost a 9-month progression-free survival in those patients who were previously progressing. And after the CLARINET trial, there was a secondary trial called the CLARINET-FORT, which increased the lanreotide frequency from 120 milligrams every 4 weeks to every 2 weeks. And although we didn't see this to be an absolute change, in select patients with low Ki-67, we did increase the time of stability. In the midgut neuroendocrine tumors, it was about 25%. In the PNET tumors, it was about 1/3. Patients in about a year's time, 48 weeks, had stable disease. So there does appear to be some benefit to potentially maximizing our use of somatostatin analogs before we move on to further therapies for these low-grade tumors. This idea of high-grade high-grade somatostatin analogs is further being investigated right now in a trial called the Sorrento trial, looking at a new agent, CAM2029. There's a typo there, sorry. And this is comparing this new compound of a high-dose somatostatin analog delivered in this liquid crystal technology versus the standard dose, the investigator's choice of octreotide or lanreotide, and the endpoint is progression-free survival. We hope to have results of this trial in this coming year, and this will help us delineate maybe a new first-line treatment for somatostatin analogs. Now let's go back to the case. We've talked a bit about this. Let's say that the patient has been on a somatostatin analog, and then you start to see that they have some times of disease stability, and then they progress. Maybe then, Diane, what would you think about as your next line of therapy here?
Yeah, so I think if the patient progressed, again, the question is by how much? Is it 2 millimeters versus 2 centimeters? Is there new lesions versus just slight increase in a couple? And then again, it goes back to the burden of disease. But I think based on NETTER-1, I tend to go to PRRT as a second-line therapy in today's world.
Yeah, I fully agree in this particular situation. You showed just before the difference between treating patients on stable disease, that this is the CLARINET data, with a median PFS of more than 3 years, or around a year or even less than a year, if we increase doses in this particular case. So it's 8-9 months of PFS. It's enough to double doses, or we need to move to the next well-demonstrated treatment line that probably is PRRT in this situation.
Okay, so we've heard about PRT. Let's talk a little bit about that. So radioligand therapy, or PRT, is really a very exciting field, and I think in all of oncology care. Certainly in neuroendocrine cancer and prostate cancer, we now have approved agents, but it is growing rapidly. Basically, I think of it as a lock and key model where we have a receptor binding to an analog, and then that gets internalized. And what we've done here is attached a radio-labeled somatostatin analog to attach to the somatostatin receptor. The radio-labeled radionuclide can either be an alpha or beta radiation. Right now, lutetium-177 is a commercially available product, but there are other products coming online as well. So we heard about the NETTER-1 trial. Hopefully most people are familiar with this. This led to the approval of Lutathera, and this was the first approved radioligand therapy that we have used in the oncology world. This NETTER-1 trial looked at patients who had midgut small bowel neuroendocrine patients, much like our case of Joanna, who had progressed on standard dose therapy. They were then randomized to receive either 4 cycles of lutetium dotatate every 8 weeks, concurrently with their previous octreotide, or move to a high-dose octreotide, 60 milligrams. And as you can see here, the progression-free survival certainly benefited the Lutathera arm, and the hazard ratio was 0.21. When we looked at quality of life, we actually found an improvement on the global health status on patients who had PRRT. As we know, some of these patients can have a high symptom burden, and being able to deal with the disease through a cytal agent such as PRRT could be beneficial. And in fact, even in some of the subgroup analysis, such as diarrhea, there seemed to be an improvement of quality of life on those patients with PRRT, specifically Lutathera. Subsequently, as well, that trial was done on midgut neuroendocrine tumors, but we've seen in other areas such as pancreas, there has been not the same level of data, I would say, but certainly there has been good data for us to indicate that there has been a response of Lutathera in pancreatic neuroendocrine tumors as well. And I think the foundation of this is really the SSTR receptor. Most recently, this year, Dr. Capdevila, who's on the stage with us, released the results of the COMPETE trial design. This was a similar trial to NETTER-1 with some specific differences. It looked at another compound, ITM-11, which was also lutetium-based, slightly different. Some of the key differences here in this trial versus NETTER-1 was it was for 4 cycles rather than 6. There wasn't concurrent SSA, and the comparison arm here was a bit more active in that it was an everolimus comparator. In addition, there was a small portion of patients, I believe around 15%, that actually had first-line therapy with this. Now, we're hearing more and more about this. We wait for the publication, but what we do know so far from this year is that certainly there's a benefit to this agent over everolimus as well, and I think this further solidifies the strength of PRRT in this group of patients who have progressed on somatostatin analogs, and perhaps even in first line. We'll wait to see some of the subgroup analysis. When we look at the safety, I think that's one of the issues we have to look at with all agents that are PRRT-based. We specifically want to ensure that we improve our patients' quality of life, and from a safety point of view, we still wait to see what the treatments are. In this trial, when it was compared to everolimus, we certainly know that everolimus actually had a higher rate of adverse events. However, we did see 1 grade 2 MDS related to PRRT, which can be a complication, and so this needs to be followed closely when we're considering this therapy. The other trial that looked at this first-line PRRT was the NETTER-2 trial, which looked at a bit more of high-grade neuroendocrine patients. These were patients who had a Ki-67 between 10 and 55%. This looked at first-line therapy, so before they actually received an effective dose of somatostatin analogs, so they really had no meaningful prior systemic therapy. They were then randomized to receive 4 cycles of lutetium dotatate concurrently with octreotide versus high-dose octreotide again. And when we looked at the patients that were enrolled on this trial, the Ki-67 median was between 16 and 17%, so there was a mix between high-grade 2 and G3 as well. We need to be very clear, though, however, that if we are considering this therapy, they have to be SSTR positive, and that was certainly reflected in this trial, because for patients who are SSTR negative, we may think of other lines of therapy, such as chemotherapy, for example. The results of this were very clear that it was favorable to first-line lutetium dotatate versus the high-dose somatostatin analogs. The median PFS was 22.8 months versus 8.5 months. And one of the encouraging parts of this, which we're seeing more and more now, was a very high overall response rates, which we hadn't seen before at this level in neuroendocrine tumors. Safety was as expected, but again, we have seen a few cases of MDS, as well as some cases of bowel perforation for those patients with high peritoneal loads. So I think we want to follow that closely as time goes on, because the MDS can sometimes manifest itself late. When we looked at the subgroup analysis in this, we found that initially the results were thought perhaps to be driven by one group or the other, but when we looked at the subgroup analysis, the pre-specified subgroup analysis, it was reassuring to see a benefit in both the grade 2 and grade 3 neuroendocrine tumors, as well as pancreas and small intestine. So it seems to be that for those patients who are SSTR positive and have aggressive disease, earlier use of PRT seems to be beneficial. The NETTER-P trial looked at the pediatric population. I won't go through this, small numbers, but it showed the pediatric population as well benefited with SSTR positive GAPNets. And right now, the next trial that's being done is the phase 3 NETTER-3 trial, which is looking at first-line PRT with lutetium dotatate, Lutathera, in patients who have lower Ki-67, the 0 to 10%, where we might have used somatostatin analogs before, but have bulky disease and are symptomatic. So I think this is going to be another important piece of the arsenal for us to understand what's the right treatment, as Dr. Reedy had mentioned out. What's the right treatment? Could it be observation? Could it be somatostatin analogs? Or could there be select first-line therapy with PRT based on the COMPETE, NETTER-2, and now NETTER-3 trial that we want to use early? The other issue that's come up most recently is if PRT works, should we do it again? As I mentioned to you, one of the risks might be an increased rate of MDS, and this is another trial that's being done now through the cooperative group structure, looking at patients who previously received 3 to 4 cycles of lutetium dotatate who've had a good response, and by that we call a good response at least 12 months of stability, and then they're randomized to receive lutetium dotatate versus what was started as everolimus but now has included other standard therapies such as cabozantinib and sunitinib in both pancreatic and small bowel neuroendocrine tumors. A trial that's completed that we anxiously wait the results for this year is the ACTION-1 trial. This is the first trial looking at alpha therapy, in this case actinium-225. This is another retreatment trial for patients who've previously been treated with radioligand therapy. The difference here is that these patients on this trial had at least a 6-month progression-free time period. So what I would say, the way I sort of look at this, is for this trial, we're looking at people who had what I would call non-resistant disease to PRT, whereas the previous trial, NET-RETREAT, are those who've had sort of a longer response. In this trial, patients were then randomized to receive the alpha therapy, RAISE 101, versus an investigator's choice of treatment, which could be everolimus, sunitinib, or high-dose somatostatin analogs. This trial has met its accrual, and we'll wait for results, again, hopefully this year. So retreatment of PRT may be another treatment option that we want to consider for our patients. So with that, I'm going to talk a little bit about a case, and then we're going to talk about other systemic therapies that patients like this may benefit from. This is a patient who is a 65-year-old male. He was diagnosed with a well-differentiated pancreatic neuroendocrine tumor. Ki-67 is 20%, SSTR positive, extensive liver mets, not eligible for surgical resection. Let's say, to make this interesting, that there's no symptoms of hormone excess that would indicate it's a functional NET. So how would you, this is a bit more complicated, I think, than our previous case. So maybe I'll start with Jaume this time. How would you start in this case? How do you consider SSA, PRT? Would you consider observation in this situation, or
no observation for sure? But we have more additional options here because chemotherapy is also a good option for these pancreatic origin tumors with a relatively high Ki-67. The problem here is that we don't know, and probably this will be discussed later on, if it's better chemotherapy or PRT. Analogs with a Ki-67 of 20%, we do not have enough evidence today. And these patients, in my opinion, should go for PRT or for chemotherapy upfront.
Dan?
I totally agree.
Okay, so we're going to talk a little bit about some of the other therapies that we have as well. I've talked to you a little bit now about somatostatin analogs and really manipulating the SSTR receptor, whether it be through the somatostatin analogs or the radioligand therapy. But beyond that, we've had a number of new developments, and I think we need to explore some of those to think about how we could best treat our patients. So I'll leave it to Dr. Reedy.
Thank you so much, Simran, for that very comprehensive discussion. So I have the honor of discussing the targeted therapies and the expanded roles they have for our patients with neuroendocrine. And so I'm also going to start off with a case. This is William, a 50-year-old gentleman who is diagnosed with moderately differentiated advanced pancreatic NET, let's say Ki-67 of 5%. initially treated with everolimus, but actually had some poor tolerance, and then subsequently had progression of, went on to receive PRRT. So now presents with signs of disease progression again, and he's consulting us to regards of what to treat next. So Simran, what would you do in this case?
So first of all, I think patients who have previously had everolimus, it's not uncommon for them to have this sort of toxicity and have it's a difficult course for patients. I guess part of it depends on the pace of growth. If it would be a moderate pace of growth, I think I would be excited by considering this patient for cabozantinib based on the Clarinet trial. And that's been a really great development in terms for us to be able to treat these patients. Certainly, if there was very rapid progression, I may consider chemotherapy, but there's certainly would be a role for a targeted agent here, I think.
Yaimi?
Yes, I agree. And now that we have additional options to treat these patients with different kind of therapies, we may delay cumulative toxicities, because if we use chemotherapy just after PRRT, we have high risk of bone marrow toxicity. If we do something in the middle, maybe we may delay this risk of myelodysplastic syndrome that we see mainly when we combine chemotherapy and PRRT.
So I think that is a beautiful segue in trying to understand, like, how do we pick these treatments and when do we use them? And the problem is, I would say, unburdened by data, or unfortunately, because we don't have data of sequencing treatments, right? Breast cancer, renal cell carcinomas, those patients don't live as long as our patients with neuroendocrine malignancies, and so we have, and they're a little more common, and so they have big, bold, randomized trials with first, second, and third lines, and they're comparing the two, and they're seeing with overall survivals who do better. We don't have that blessing. And so we really have to think in this nuanced sense of the patient in front of us and how we tailor and personalize that treatment to make sure that the eye on the ball is how do we keep with our patients with us for as long as possible and as well as possible? How do we keep their bone marrow safe and not damaged? How do we keep their quality of life always in our mind of what's going to help them live well? And then how do we make sure that the cancer doesn't grow in front of us? So molecular targeted treatments have been around for the last 15 years plus. Dr. James Yao is the first to sort of think about mTOR inhibition. And because we don't have great, what we call preclinical models, cell lines, and animal models to help us, a lot of this actually was derived from clinical experience of hereditary syndromes of what were associated with our disease. But we knew that VEGF inhibitors as well as mTOR inhibitors were potentially very helpful for that very reason. And so everolimus came onto the platform close to 15 years ago, which is kind of crazy. I can't believe I'm dating myself
You're
here.
aging all of us. Yeah.
I know, exactly. I'm sorry, I had to say it. But we had Radiant 2, we had Radiant 1, 2, 3, 4. And so take-home message is it actually works very well. I think there's no question an advanced pancreatic net, it can keep the cancer controlled, as well as lung net and the non-functional tumors. Radiant 2 was a little bit of a mixed bag with functional tumors, and there were some troubles with that design. But in general, this is an FDA indication for non-functioning GEP nets and lung as an option to try. Then we have sunitinib, which was not positive in the so-called extrapancreatic neuroendocrine tumors, but was a positive study in pancreatic neuroendocrine tumors. So another option, and recognizing cross-trial comparisons, this was actually the sunitinib and the everolimus were both in the same New England Journal of Medicine, and the PFS were almost identical in about 11 and a half months to keep the cancer controlled versus about 4 to 5 months for placebo. So these are targeted agents that we've had now for close to 15 years as options, mostly for pancreatic nets and non-functional GEP nets. What about sorafenib? So this is a multi-kinase inhibitor of VEGF plus FGF plus CSF1R inhibition. This was a positive study, but it was done in China. And so when they went for FDA approval here in the United States, they used that data plus a small cohort of patients in the United States. Again, because it was a positive study, they were hopeful, but this was not given an FDA indication here in the United States because of the extrapolation and asking for more of the patient population that would be here. So that is a TKI that is, again, VEGF. There's sort of a current theme here on VEGF and mTOR inhibitions to be active in our disease, but that one was not FDA approved. But then came cabozantinib, and Dr. Chan did this study. And what was so beautiful about this study is, as I said before, we don't really have great sequencing therapies, but this trial allowed us to say, okay, the patients have had to have had some lines of therapy before they got this treatment. And the good news is, typically, I'm biased to say, I would worry about giving a tyrosine kinase inhibitor as opposed to PRRT or some sort of cytotoxic therapy in patients that have had multiple lines of therapy and have already been treated with a lot of these. But that was the question that we asked. Could we be bold and say, does this TKI work in this more heavily treated patient population? And so it was disease progression within 12 months of randomization. They've had to have had more than one, including somatostatin analogs. And it was an extrapancreatic as well as pancreatic neuroendocrine tumor. It was 2-to-1 randomization, and it was a placebo-controlled trial that allowed for crossover. And so this is a little bit of a wordy slide, but what's really important to note is if you move over to the PRRT arm, almost 60% of all the patients that were on this trial had PRRT. So this was a heavily treated patient population. They had almost 80% of them had everolimus, and about a third of them had CAP-TEM or some sort of chemotherapy types of treatment. So much more of a heavily treated patient population. And I think this really did really helpful for us, for our patients of today as well as tomorrow, to understand how we can sequence these therapies, because it was thankfully a very positive study. And you can see here, most notable, like many tyrosine kinase inhibitors, was more impressive in the pancreatic endocrine arm. They had a progression-free survival there of 13.8 months for the cabozantinib versus 4 months for the placebo. And it was positive in extrapancreatic, including small bowel, not as much, which in PFS of 8.4 versus a placebo of 3.9. Again, not surprisingly, with tyrosine kinase inhibitors, response rates are generally not high, particularly in the extrapancreatic neuroendocrine tumors. So unlike the PRRT that we heard before, that does have very high response rates in grade 2, 3, and even in the NETTER-1 had a higher response rate than this. Cabozantinib had a 5%, so very low in terms of tumor shrinkage. But in pancreatic neuroendocrine tumor, it was close to 20% at a 19% confirmed objective response rate. So before we move on, I want you to just take a moment to answer a follow-up question on the treatment. And as you're doing that, I will say, again, tyrosine kinase inhibitors in general, the good news is that they are, I would say, gentler on the bone marrow and other things that we as oncologists really worry about. The not so good news is for some patients, grade 1 to 2 fatigue all the time or mouth sores all the time. That is a quality of life issue that we have to be careful for. So hopefully you all did your question. Okay, and that is the cancer treatment-related adverse event. So the CABINET study was a 60 milligram dose, which many of us are a little bit worried that it can be quite high. And so you can see here that grade 3 to 4 events were as high as 2/3 of our patients. So it was mostly fatigue, diarrhea, and some elevated blood levels, including liver enzymes. But this is not a trivial, again, grade 1 to 2 fatigue for our patients all the time on a drug that you're taking every day is something that we have to be aware of. So when you think of PRRT, it's 4 treatments every 8 weeks and then you're done. That's kind of a nice thing. But again, given the responses and the PFS, it's a great drug that we like to use, and we do use it. We just have to be careful with those side effects and appropriately dose reduce as needed. But this did say, despite those side effects, the quality of life questionnaires did suggest that for both pancreatic as well as extrapancreatic neuroendocrine tumors, the quality of life surveys that were blinded favored the cabozantinib arm over the placebo. And again, this is because it works. And the tyrosine kinase inhibitor was inhibiting the cancer-related side effects for this patient population. So one of the really great opportunities, again, from this trial is it included LungNet. And so this is a really nice sort of follow-up to that with a subgroup analysis of looking at lung and thymic. These are neuroendocrine cancers that are unfortunately typically more aggressive with a little bit more limited treatment options, in part because we just don't study them as well as we would like to because of the rarity of this patient population. But this was also positive subgroup analysis where the cabozantinib arm, again here, favored as compared to the placebo. So another very nice option for our patients in LungNet. And as Simrang said before, what's beautiful about this is we do have many patients that are somatostatin negative. And so we are so proud of the PRRT and the work that's been done to use that for patients with treatment options. But what do we do when it's negative? Chemotherapy is not easy. Cabozantinib is not easy for everyone, but I will tell you it's a lot gentler than some of the chemotherapies that we would typically recommend. So to have this now for patients with GEP-NETs and lung that are somatostatin positive can be an incredible, valuable tool to use. So back to William's case, again, 50 years old, diagnosed with moderate differentiated advanced NET, initially treated with poor tolerance to everolimus and subsequent neuroendocrine. We did consider initiating William on cabozantinib. So when Simrang or Yami, when do you consider using these TKIs, and would you use it in earlier lines of therapy? This is a really important question because we know now it works and it's something that we can save, if you will, to patients with more advanced disease, but would you consider using it earlier?
Well, that's a good question, and I hope that we will have a trial in the future that will answer this question. But as you said before, it's extremely important to have evidence, good evidence, academic trial, phase 3 positive, that MKIs work after everolimus, after PRT, and since we have this trial released, we have that evidence. We were using that in the clinics. We're using sunitinib, we're using other MKIs off-label because we didn't have any options. Now we have that option. I think that there will be options to treat these patients with MKIs in earlier lines. And again, my concern is how we may delay accumulative toxicities of the systemic therapies to try to do what you said before, to have the patients as much as we can with us and with the best quality of life and biology function. And it's not easy because sequential therapies are extremely difficult in NETs. I don't know if you agree or not.
No, I totally agree. I think, we've had a lot of uncertainty in the world of TKIs, and I think this has been a definitive trial for us. So I agree with Yami that really cabozantinib is generally now our TKI of choice. I think for some patients, earlier lines of therapy may make sense. Patient preference plays a role. Not everybody can travel for PRT or wants to, or the radiation safety considerations can be difficult for some patients. For patients who potentially, as you mentioned, the response rates aren't the same. So for those patients who were really aiming for a goal of stability and can manage the side effects, or we can work with them to manage the side effects, I think that it does make sense to consider it early in select patients.
And what about the toxicity that you monitor for once you initiate the drug? I mean, do you start it at full dose, and how do you do that?
So when we look at the trial, we do notice that there was a fair amount of dose reductions. I think this is a case of, as it is with all TKIs, is really good communication with our patients, telling them what to expect, telling them what we're looking for, working with them closely, phone backs, bringing them back to sort of discuss and to be ready for what's aware and to be prepared. So I start my patients at a 40 milligram dose and then try to work up to a 60 milligram dose. And then again, it's individualized.
Yeah. Okay. I think before we move on, please take a moment. Sorry, we're running a little late. To answer a follow-up poll on addressing practical questions as it relates to TKIs.
And maybe, I was to follow his comment, because we have these conversations quite often. If we may start with the standard doses and then decrease if we see toxicity or vice versa. I think that the Europeans are stronger than Americans.
It's true. It's true. It's very true.
And we can deal with toxicity much better than you in general. And the problem here is that if we want to reply those data on PFS and overall and responses, probably we need to start with the correct doses, that this is the standard dose. If we see toxicity, then we can go down quickly. but we may lose, and we don't know, and I'm speculating here, but if we lose the opportunity because we are starting with lower doses. So 40 milligrams is better tolerated than 60, but it's not extremely better tolerated. And we don't have this data in NETs, but we have this data in thyroid. And we did that with lenvatinib. 2 different doses, because high doses of lenvatinib seems that it cannot be supported. And we compared that in thyroid cancer. Responses were less, PFS was inferior, and the toxicity was exactly the same. And it was a blinded study. So sometimes perceptions, and maybe we have different, I don't know, cytokine or CIP polymorphisms or something that we may tolerate better the drugs in Europe than in the US.
I mean, we got like, I guess we got the European perspective and the American, and we'll leave it to the Canadian to bring the rational perspective in between. I think the key really though is proactive toxicity management.
That's for
And
sure.
I think that's the key, is that we just want to make sure you don't start the patient on the treatment and then, see them, 2 months later. You want to be proactive with discussion, with good communication. I mean, on the trial, the median dose was slightly below 40 milligrams. So I think the idea is absolutely we should aim to get the patients the most effective dose that they can tolerate. And the way to do that, whether you start at 60 or whether you start at 40 and move up to 60, is proactive toxicity management. Yeah.
100% agree.
Okay, so we have a bunch of QAs too. Okay, so in summary, I think we have discussed that there's multiple systemic options, thankfully, and this is a beautiful problem to have in deciding which one to have, because the landscape just keeps broadening, which is just so wonderful. The characteristics and treatment goals are really what we're using right now in the absence of randomized data with sequencing of these drugs. Certainly a multidisciplinary approach is critical, but these treatment options show that particularly PRRT is expanding earlier rather than later, and that the TKIs have a place in both early as well as later. And we're hoping that predictors of first treatment response, as we learn more about the science, could help us optimize that treatment. So one last question before we move on to the last part.
I think we'll do it at the end, yeah. Okay, so we've heard a lot today about neuroendocrine tumors, and thank you for the questions. We're going to address them during the question and answer session. But one of the areas where we haven't seen a lot of progress, where there's been a huge unmet need, has been in neuroendocrine carcinomas, these aggressive cancers. And it's very exciting that we have Dr. Capdevila to talk to us today about the new cares and the new advances we're making in neuroendocrine carcinomas. Dr. Capdevila.
Thank you. And yes, this is also a neuroendocrine neoplasm. You said 15 years of sunitinib and everolimus. I remember slightly earlier than this, 15, the last 20, 25 years. So we started with analogs for NETs, treating hormone syndromes with no idea on the anti-proliferative effect, streptozotocine in Europe that you don't have in the US, and nothing else. So in 2 decades, we have this complex scenario that you both showed, and it's fantastic that we have different programs to sequence therapies. Yeah. We don't have that problem here. And this is a real unmet need. And this is why this is the best part of the talk today, because this is the challenging. So this is how we may change the future in the next few years. We will improve the future for NETs, have no doubts, but we can change the future in neuroendocrine carcinomas. And to do exactly the same, we can start with this typical case, not so typical. This is a lady, 79 years old, that was diagnosed with a primary biliary tract neuroendocrine carcinoma. This is frequent, of course not, but it's extremely important to diagnose that properly. So, as you can see here, different liver lesions. So which could be the first treatment option? And maybe, and this will be a short discussion for sure, but maybe Diane, which is your first treatment option for this patient, 79 years old? Well, she was doing well before the diagnosis.
Yeah, so I think platinum-based therapies, and in a 79-year-old, I would be a little bit worried to use cisplatin, so I would use a carboatopicide regimen at dose reduction.
So discussion done.
That's all we got.
It's ridiculous that we have been dealing with that for
40
many
years,
decades
50 years,
with no real advances. So the problem is, and I'm sorry if someone here is dealing with lung cancer, but the problem is following the lung history. So extrapulmonary neuroendocrine tumors are not small cell lung cancers, are far from being small cell lung cancers. We had advances in lung neuroendocrine carcinomas much often seen than in extrapulmonary NECs. Why? Because extrapulmonary NECs are less frequent. You can see here, and I think that this percentage is not accurate enough. The percentage is higher. The problem is the proper diagnosis. They are heterogeneous, different origins. We may have GI, GU, different concept that this is the prostate neuroendocrine carcinoma, different even gradings on the carcinoma, gradings meaning the Ki-67 value. So all these problems have a clear deficit on the diagnosis and the proper design of clinical trials. If we go for the first line, we have a very limited impact of the platinum-based chemotherapy on PFS, OS, and also responses. Usually what we see is half of what we may expect in small cell lung cancer. And there's nothing on label, and there's nothing even with good data after failure of platinum-based chemotherapy. So we have been dealing with different kind of algorithms that we may stop after the first-line therapy. And part of this first-line therapy is platinum-based chemotherapy, and a huge, sadly, but a huge percentage of patients that go directly to best supportive care because they cannot support the first-line chemotherapy. So this is the poor reality. We can do something else. Of course we can do. The first thing is what Simran said in his second or third slide. We need to do a good pathology diagnosis. If we confound a NET-G3 or a NEC, we will fail on our treatment decision. Then we can do something else on precision medicine. And these patients are good candidates for molecular profiling. It's rare to find an NTRK fusion, it's rare to find a RET fusion, it's even rare to find an MSI high, but they are there. And in a particular setting of these patients, those that are coming from the colon, we have around 30% of BRAF B600E mutations, that they should be treated as a colon cancer. If you look at the indication of BRAF and EGFR inhibitors in colon cancer, they say colon cancer. They don't say adenocarcinoma of the colon. So we can include here neuroendocrine carcinomas, and we are on label. So platinum and etoposide or platinum irinotecan, depends on the part of the world that you are dealing with these patients, is first line. Second line, the most frequent second line is best supportive care. And if not, irinotecan-based, oxaliplatin-based, this is the GI oncology with very few good data. Here you can see what we may expect. So as I said before, half of the efficacy in small cell lung cancer. So 30 to 50% responses. In first line, PFS of around 6 months, overall survival of around 1 year. In second line is ridiculous what we can obtain with oxaliplatin, irinotecan, or even temozolomide or topotecan. I said that at the beginning because we all have one patient with an NTRK fusion, with a RET fusion, with an MSI high, with a NEC diagnosis, and it's day and night, so they change completely, and we can save those lives if we use the NGS testing upfront. Maybe we will need to test 150 patients to find one, but it deserves to treat this patient and to find that. If not, what we have, we try to do that, and of course always I like to see my name on the slides and the things that we do in Spain and in our national working group. But look at here. So we had 2 big clinical trials in neuroendocrine neoplasm, more than 100 patients in both trials. Here you can see only the subgroup of neuroendocrine carcinomas with immune checkpoint inhibitors and the combination of cabozantinib and atezolizumab. Both trials are clearly negative. No responses in NECs. immunotherapy, immunocombinations. Even we had some initial data with nivo-ipi that it had some role there. Look here. So responses are anecdotal. No MSI high in neither of the patients that we treated. We have few anecdotic responses, but not good enough to continue developing those therapies, those immunotherapies, without a good biomarker in the setting. So 2 big negative trials from our group. I'm so sorry. We are doing something different. Of course, we are trying to repeat what we saw in small cell lung cancer in extrapulmonary NECs, combining chemotherapy and anti-PD-1, anti-PD-L1 therapies. We did a small trial in Spain, combining platinum-etoposide and nivolumab. Well, medium responses, around 50% overall response rate, PFS around 6 months. It's not something spectacular, but maybe something is there. Here in the US, you are a much bigger country, much richer than us. So you are doing a phase 3 study, almost completing recruitment. So congratulations, it's not easy. I really hope that you may change the first line therapy in extrapulmonary NECs, adding atezolizumab to chemotherapy or to maintaining also with atezolizumab after induction chemotherapy. We will see if we may repeat the data on small cell lung cancer. We will see. But the hot topic, of course, of neuroendocrine carcinomas is the DLL3 expression. So you probably you remember that this pathway that it's typically related with the neuroendocrine differentiation. We have several negative trials trying to block this pathway in small cell lung cancer. So we don't need to block the pathway. We need to identify the cell, that it's different than the normal cell. This cancer cell can be identified by this DLL3 expression. DLL3 expression in small cell lung cancer, again, it's over 98% of the cases. We are dealing about 80%, 70 to 80% in GI, GU, and even in unknown primaries, that is slightly lower, but the biomarker is there. So here you have only an example of the immunotherapies that are being developed to try to engage the immune system based on the DLL3 expression. But it's not only immunotherapy. We have ADCs, and we will have PRT directed to DLL3. So the future, at least now, it's more than promising, I guess. So what we did is this phase 1 study, and this phase 1 study was smartly designed, and I'm not the PI, so don't worry, but it was smartly designed because we separated small cell lung cancer and extrapulmonary NECs. And I'm here today talking about extrapulmonary NECs because we had an independent cohort to have a good prospective data. And probably this will help to bring obrixtamig to the market based on this phase 1 study with this good design at the beginning. So obrixtamig is a T-cell engager, bispecific antibody that targets the DLL3 expressed in the cancer cell and the CD3 that is expressed in the T-cell. And they bring both together and produces this cytolytic synapse that produces a cytokine release, that this is one of the problems of the side effects, but it also recruits other immune cells and finally the apoptosis of the cancer cell. So this is the mechanism of action. And I will go quickly to this data because I repeated now. So we presented data this year at ASCO and also at NANETS a couple of months ago. So we have 2 regimens with step-up dosing to try to avoid the cytokine release syndromes. And I will show you only the data of those patients treated with doses that we expect that are active. Extrapulmonary NECs, all of them pretreated at least with 1 prior systemic therapy, and all of them DLL3 positive. And again, here, based on this phase 1 study, we are creating a companion diagnostic biomarker for at least this T-cell engager. So we screened more than 200 patients. We know that this 80% expression is based on this phase 1 study. 80% expression, and this 80% expression is divided half and half between high and low DLL3 expression. And low DLL3 expression means less than 50% of the tumor cells positive for DLL3, and high is more than 50%. And the good thing here is that the vast majority of the patients in high are really high, and those that are low are really low. So this is what we presented at ASCO this year. The difference between the high and the low expression of DLL3 in the patients treated with obrixtamig immunotherapy with extrapulmonary neck patients. So this is a phase 1 study, so toxicity. Cytokine release syndrome is there. It's a mechanism of action. The good thing is that what we expected to see high percentage of grade 3 or even greater CRS, we didn't saw that with these step-up doses, so we prepared the body to this cytokine release syndrome, and the vast majority of patients will have grade 1 and grade 2, and very few of them grade 3. And the other thing here, the two other additional toxicities that I want to highlight, the first is the GI, that is something that it's not probably well known, but we have this this geusia, this changing in the flavor of the food that may increase the risk of having cachexia and anorexia and sarcopenia at the end. And the other that is important to highlight are the ICANS. This neural toxicity that is not easy to identify. I will show you something later on. Efficacy. So finally we see efficacy. Look at the sentence there. 70-80% of the patients were treated with obrixtamig in third line or beyond third line. So it seems that it's few years ago it seemed that it was impossible to see patients with NEC arriving to third, fourth line. Now we are starting to have some patients arriving there, and we can see responses with this directed immunotherapy. Responses are around 40% of the patients in those that have DLL3 high, no responses in DLL3 low. We had some disease control rate, so probably some efficacy we can see there, but not enough, probably not enough percentage of expression to have responses. Regardless the origin, GI or GU, the same probability of having this 40 to 50% probability to have a partial response, and a disease control rate between 60 and 70%. And another important point here is not only the percentage or the probability to have this response, is the quality of the response. So a median duration of response of 8 months in third line in a NEC, it seems that it's impossible. It's difficult sometimes to believe that. When you see the first patient, then you are fully convinced that this is possible. And this is immunotherapy. So when we did the cutoff, we had some patients still ongoing. And you will see that the patient that I showed you at the beginning is one of the good responders. This is because she's here. This is not the only drug under development. You know that tarlatamab, for instance, is really approved in small cell lung cancer. We are starting to test that in extrapulmonary NECs, but we don't have really data yet. And these three specific T-cell engager was presented a couple of years ago at ASCO. So it targets not only the DLL3 and the CD3, but also targets albumin to try to increase the half-life. So mainly patients here were included with small cell lung cancer, but we have a small cohort of extrapulmonary NECs, again with the same percentage of responses. So it's not by chance that we saw responses in obrixtamig, so it's a class effect probably, what we may expect with these T-cell engagers in DLL3 positive disease. And this is a very extremely new data presented 2 months ago at NANETS. So we are running the phase 1 study combining chemotherapy, platinum etoposide, plus obrixtamig in DLL3 positive NEC, extrapulmonary NECs. So the first 20 patients have been included. 2 important points here. So it seems that when we combine chemotherapy with these T-cell engagers, we reduce the risk of immune-related symptoms, at least the CRS. So this is important to try to avoid hospitalizations, to try to monitor this potential grade 3 CRS. Look here, so grade 1 CRS in 50% of patients, only 60% of them grade 2 and no grade 3. It's true that this is the beginning of the study, initial patients, but the safety profile, it seems that it's better than immunotherapy, and look at the efficacy. This is something that is really promising. So over 70% responses, duration of the responses of 9 months. It's too early to have good conclusions, but the phase 1 study at least is positive for toxicity, no problem, and you will see the phase 3 in the near months and start recruiting. We have another pool here. If you want to answer that in 5 seconds. because I want to share with you a couple of additional thoughts. Well, 5 seconds. So this patient received chemotherapy. As Diane said, the probability to have a high toxicity in a 79-year-old person, it's high. So this is what happened to this patient. So second treatment option, Simran, the topotecan.
I mean, I think there is no second-line treatment option that we know of. And so this is why what you described is so encouraging. So I would want this patient on a clinical trial, and given that she has DLL3 high, I think she'd be an optimal candidate for the trial.
So, of course, fully agree. And as you can see, the patient was included in the study. This is why she's here. But how many trials do you have open in your environment that you can include patients with NECs, extrapulmonary NECs in second, third line? Oh, come on. It's almost impossible to find trials. And this is one of the opportunities that we have now to change this, let's say, bad behavior. So the patient was included. Look at the partial response that she obtained only after 6 weeks on therapy. At the time of data cutoff, she was on therapy for 2 years and a half, at least. At least. Side effects to monitor. So this is what I said before. CRS is what guided the monitoring of these patients in the phase 1 studies, with tarlatamab, with obrixtamig, with the news that will arrive that they have still not a name. The CRS is the problem that we had in our minds at the beginning. The reality is that if we do this proactive side effect management, these patients will have grade 1. And grade 1 means fever, only fever, nothing else. Like with gemcitabine, that it produces fever, so the same here. The problem is that it's not only CRS. We have this GI toxicity that this should be monitored. I'm afraid about sarcopenia, and the good thing here is that we are not lung cancer physicians. We are NET physicians, so we are used to treat our patients in a multidisciplinary team. So we have endocrinology with us, and we can try to save this GI toxicity to our patients and to prevent the risk of sarcopenia. And what I'm afraid is about the ICANS. Do you know what means ICANS? ICANS means any kind of neural toxicity or neural symptoms that you may not explain easily. This is an ICAN. 79-year-old person with a cancer after progression to chemotherapy, who doesn't have confusion, who doesn't forget some things, who doesn't know how to write her name properly with 79 years old. This can be ICANS. And the problem of ICANS is that if we have a CRS and we want to treat them, so grade 1 and grade 2 are managed in our offices or in our hospitalization, so means oncology, not intensive care units. Grade 3 and 4 goes to the intensive care unit, so it's out of my expertise, and I have never seen a grade 3 or 4 with obrixtamig. That is my best experience, but we have seen a lot of grade 1 and 2. Grade 2 means that the patient needs observation, hospitalization, we can see some hypotension, some breath problems. It's easily managed with tocilizumab. It recovers quickly. But it doesn't mean that we need to use this therapy in grade 1 CRS, because if we have ICANS, we can worsen them. And ICANS can produce the death of the patient. Because if we do not identify that, it may evolve even to coma. So ICANS are dangerous and not easy to diagnose. So we need to learn, and this learning curve needs to be quite quick. I think that we have other points for discussion that we may leave that for the end. So this patient had no real side effects, and this is one of the good things of immunotherapy. When we don't have side effects, we don't have even a single side effect. So this is fantastic. But again, we should be confident with these new drugs, but we need to learn how to manage those side effects that are not easy to diagnose. the last pool, I guess.
So people can answer this on their own as well.
Okay.
Yeah.
So my learning points at the end. So I will start again with this first sentence that I said. So it's critical to do a perfect diagnosis in the neuroendocrine world. We should not confound not only adenocarcinoma and neuroendocrine cancers. Those adenocarcinomas of the pancreas that are there for many years are not adenocarcinomas, are neuroendocrine tumors. But between the neuroendocrine tumor and the neuroendocrine carcinoma, and mainly the G3 net and the neck and the low neck, that probably will arrive in the classification of the WHO classification in hopefully in a near future, but not all the necks are the same. It's not the small cell lung cancer, but we can learn how they are doing the things in a small cell lung cancer, being smarter and trying to move and to bring the therapies to the patients as soon as possible. Chemotherapy is there. Today we cannot say that we can move without chemotherapy, at least in first line, but the efficacy is much, much less than we can see in small cell lung cancer. Personalized medicine, NGS is there, and I think that I tried to convince you that DLL3 is not only a promising target for neuroendocrine carcinomas, it will be a reality in the next few months.
Okay, so we have a brief amount of time for questions. We've had a lot of good discussion already, but maybe along that lines, Dr. Capdevila, DLL3, you mentioned it a few times, how excited you are about it, and I think probably Diane and myself would share that excitement. When do you test for DLL3, and when do you think it should be tested for?
This is a very good question. So DLL3 is there from the very beginning, so you can do that in the original tumor sample. The problem is that it's modulated over therapies, with therapies, mainly those that are directed to DLL3. So it's easy to find downregulation of the DLL3 expression. And this probably is one of the mechanisms of resistance to this kind of immunotherapies.
Dan, in your talk, you talked a lot about some of the new advances that we've made. Has this changed your algorithm for patients? And if so, can you describe about what has been the major changes that you've seen in the last few years and how you treat your patients with neuroendocrine tumors?
Yeah, I think that's a great question. So probably the most transformative was NETTER-2. Because I think traditionally, at least in the US, because we didn't have PRRT. You Europeans are very lucky, and they've had it for 30 years. We did not until 2018. And so it was a therapy that I think we were all a little hesitant and reticent because of the rare but very serious side effects. So we would sort of use somatostatin analogs, then targeted therapies, then maybe even chemo, and then PRRT. And then now with the NETTER-2 data, I think particularly in those higher grade, higher burden of disease, we want to use that earlier rather than later because it's such a wonderful drug in terms of the progression-free survival and putting those patients with disease control on the order of, again, 2.5+ years. The cabozantinib data as well. So I think I misinterpreted that tyrosine kinase inhibitors would not have efficacy after heavily treated therapies like cytotoxics and PRRT, and yet it did. So those, I think, are the two sort of ones for me that changed the way I manage these patients.
And maybe for both of you, one thing that maybe we're a bit behind in neuroendocrine tumors is molecular testing. And maybe we're starting to see now that door open a little bit. What molecular tests do you think should be done for our patients, and when would you consider them? Maybe Yalma, you first. And what is the role of NGS and WGS and molecular testing? And
yeah, this is another good question, and that we need to. So we will not have enough evidence in the future, so we need to make decisions now. For neck patients, I believe that we need to do large panels because we don't know what we are looking for. If we have a colon neck, and BRAF, it's 3 hours to have a BRAF basic 100. So I cannot imagine a patient with a colon neck without a BRAF status. It's true that if we want to do a large panel, not everyone can do that easily, but probably here in the US you are much lucky for that, not for PRRT. So NGS for necks for sure, upfront, at least upfront. And those nets that are not going well, and maybe you can complete that for net, Phil.
Yeah, I think that we we kind of had envy for a long time from our GI colleagues and our colorectal colleagues that could use this next generation sequencing and offer opportunities with targeted therapies. And the problem with neuroendocrine tumors are that, most of our genes are tumor suppressor genes that we just have not figured out how to target. And even those epigenetic types of alterations that may affect protein expression, but really are not driving the cancer. Maybe that's why it's slower growing, maybe, and that's a good thing. But it just, and we and others have done lots of opportunities to look at next generation sequencing. But I think your point earlier is well taken. If it's 1 in 150 and that's a game changer, we should find it. And it's getting a lot easier to do those platforms. So I think our whole sort of paradigm has changed. I think there's no question for the neuroendocrine carcinomas, because we believe many of them are adenos transformed into these neuroendocrine carcinomas, and that they can have those genetic alterations that can be targeted. That's, up front, we like to do that across the board for all NECs. For NETs, I think for pancreatic neuroendocrine tumors and others, I just still think small bowel, we don't find it.
Yet.
You just don't see it.
And another point that you just said now, it's true that we have cheaper and cheaper platforms, but we may lose some alterations, and mainly fusions. And again, if we want to find this out of 150 cases, we need to do large panels. And this is more complex, but if we do that, we should do the best. If not, we may lose the opportunity.
So unfortunately, we're out of time, but I hope we've been able to have a good discussion today and convey to you, both in person and at home, the incredible amount of work that's been done and the progress that's been made in neuroendocrine cancers. I would say it's probably one of the fastest growing fields in terms of new treatments. You heard Dr. Reedy talk about cabozantinib and Lutathera, first line in the NETTER-2 trial. You've heard Dr. Capdevila talk about what's the first really advance in neuroendocrine carcinomas with ibriximab in quite some time. Very exciting times, a lot of new treatment options to offer our patients, but still a lot of questions remain. So hopefully in subsequent years we'll have more answers and inevitably more questions. So thank you to the panelists, and thanks
for
coming.
coming.
Thank you.